everybody. Good afternoon or good evening for those who are watching from far. We are in Italy. Hello, I am Waduda. I am product specialist for Gloreha, the robotic rehabilitation glove. We are a company based in Italy. We produce robotic rehabilitation devices for neurorehabilitation. And today we are pleased to host this webinar in collaboration with Dr. Molteni, head of rehabilitation department of Villa Beretta Costa Masnaga in Italy, and the physiotherapist Alejandro Lozana from Spain, from IRF La Sala Institute in Madrid. So we are going to stay together for about an hour and talk about the always up-to-date topic of neurorehabilitation and neuroplasticity. It is a very interesting topic and we have always something to discuss about it. So it is a pleasure for us to host this webinar today with you. Just to start, I want to thank you also Dr. Vecchio and his students of the Catania University, his physiatry students, for the participation to this webinar. And I want to just tell you that this is the first of a series of webinars we are going to host, and we are going to see much more about neurorehabilitation and robotic. So just to inform you, we are a lot of people today. We're really glad of this huge participation from all over the world, in Italy, Malaysia, Croatia, China, Singapore. We are from really everyone from around the world. We are very happy. And just to know you better and just to introduce yourselves also to our speakers, Dr. Molteni and Alejandro, we are going to make you just a couple of quick questions just to know the public who is watching us. So now you're going to see a survey on your screen asking you what is your profession and if you use robotic devices in your activity. This is just to know a little bit your participation, where the activity you do. So it is also to give a little bit of information to our speakers also. And at the end of this survey, we are going to share the results also for you to see which results we have there. And another thing I want to specify you. So first, the Dr. Molteni is going to have his speech, then will join us Alejandro, and then at the end of the two speeches, we are going to have a little bit of question time. So if you want to make a question or to Dr. Molteni or to Alejandro, just please write them on the Q&A section below. I will read the questions and make them to the two participants. If you want to specify to who you're going to make the question, just please write down. And we are going just to have a little moment speaking and exchange this idea together. So at the end of the webinar, we're going to have this little moment. And thank you very much for the participation. We are very excited about this moment. I think that maybe we can just close the survey and we can share the results with everybody. Let's see. So we have a lot of physiotherapists. We have a lot of physiotherapists also and occupational therapists. I'm very glad to know it. And we have a lot of people using and not using technologies in rehabilitation. Thank you for this quick information. So thank you again. Thank you again to Dr. Molteni and Alejandro and Dr. Vecchio for the participation. Thank you very much. So just let Dr. Molteni speak now, and thank you. See you later.
Thank you, Waduda, to introduce me, and thank you to the Hydrogenet team to organize this webinar. And it's a pleasure to share all this information with the participant, and particularly I would like to thank Michele Vecchio to attend this meeting too. Now I will try to share my screen. I think that It's okay? Are you able to see my slides? Waduda?
Yes, we are seeing everything. Yeah, perfect. You can go. Thank you. Yeah, perfect.
It's okay. Thank you. Then we have to discuss about neuroplasticity and robotic rehabilitation. And I would like to start from a concept that exercise that we are doing using any technological support is like a drug. Then if it's like a drug, we have to be able to define the best drug, the best dosages, and the duration of the treatment that we are able to perform. But using this Francisco Varela point of view, it's possible to look our patient in terms of people that would like to have some support to restore function. And then it's possible to think that we would like to restore motor ability. But what means motor ability? Motor ability means something very complex because means something related to cognition, something related to control, adaptation due to some biological changes in our brain or in our muscle and so on. It means that to change our motor ability, we have to try to use a lot of different ways to reshape our system and motor control. And obviously, technology is very important to do this. Then technologies is like a neural interface able to promote neuroplasticity. Neuroplasticity is a term, and technology too is a term very large, and particularly when we would like to stress the concept that we would like to use robotic system or virtual reality or any other technology, we stress the concept of cyber therapy, and means that the relationship between the therapist and the patient is a relationship through technologies able to share experience and treatment from the physiotherapist to the patient. But when we start to use technologies, and particularly robotics, a lot of people start in terms of I have to use something able to perform an action. And repetition of movement and number of repetition are very important, obviously, but it's not just the only focus that we have when we are using some technologies. Because if action is very important, it's very important the concept of reaction through technologies between patient, technologies, and the world around the patient. And then it's very important to stress the concept of interaction more than action. And when we have activities related to reaction and interaction, it's very important to differentiate the ability to perform something under control, voluntary control, in an adaptation to the situation that we have to face, using some automatic system able to react. And it's very important the modality that we use in terms of control, in terms of feed-forward control or feedback. In any case, the experience of the patient and the interaction between patient and technology, physiotherapist, technology, and patient is under the umbrella of a control in terms of feed-forward or feedback. In this slide, I try to stress the fact that when we think how to perform exercise, to reshape the system, to stress plasticity, sometimes we look the patient and the technology that we use in terms of biomechanics. And this is the typical example. We have lower limb, gait training, biomechanical gait, how to use technologies to perform gait training. And this are some typical wearable robotic systems that we are able to use to perform gait training in spinal cord injury, traumatic brain injury, or stroke using different systems. In any case, I don't like to move deeply how the control of this system interact with the patient. But in any case, we look lower limb, gait training, wearable robotic system, plasticity related to this one. But look, this is the control of the lower limb just focus on spinal level. Means rhythm generator, means pattern EMG, means inter-limb coordination. But if we look the real motor control of the gait and the lower limb, we have to focus not only on spinal level, but we have to focus on the global control related to visual sensation, somatosensation, vestibular sensation, visual cortex, premotor control, and then motor control. That means that depending on the technologies that we are using and where we are using these technologies, we are able to stress plasticity in different way and at different level in terms of plasticity of visuomotor control, in terms of coordination between vestibular sensation, somatosensation, premotor program, and motor output. Then we have a very complex system able to maintain under control our body during gait, able to interact with any different technology during gait. Just to discuss about plasticity, training, and technological device that we are using, if you look this general overview of the motor control, sensory motor control of gait training, it's quite obvious that if you are performing a training over ground, vestibular sensation will be complete and visual sensation will be completely different compared to training on a tapis roulant, on a treadmill. Then where you are working is very important because visual motor coordination is very, very important in terms of modulation of our motor control and then in terms of plasticity of the system too. If we look different possibilities to use any technology to perform upper limb training, is quite the same. It's possible to control a lot of different things. It's possible to use a lot of different ways to stress the system, to reshape mode of control, and to have more plasticity using different technologies in different situations. Then, at the end of the story, we would like to use any technologies to increase dynamic control of complex network using interaction and nonlinear changes able to change the experience of the patient. That means that when we focus on patient experience, technologies to perform rehabilitation training, and plasticity, we have to look the problem in terms of intention to move, intensity of the treatment, engagement of the patient, embodiment of the body that we are able to reshape in terms of motor control, sensory motor control, and the embodiment of the technologies that we are using to perform any kind of treatment. Then intention. Intention is more important than the number of movement that we are performing. Intention to move. Intention to move means that using different systems able to perform different exercise, we are able to perform exercise able to stress parietal lobe, cerebellum, prefrontal cortex, frontal lobe. Then means that different exercise using different technologies will be more specific for specific area of the brain. And using technologies, using intention and engagement of the patient, it's possible to learn through imitation. What means? Means that it's possible to use our ability to see what happened during exercise, to look what happened, and to have some predictive coding able to modulate inhibition and excitation of this different pathway, able to control upper limb, lower limb, the trunk, or the global activity that we are doing. And when we are using this motor control related to visual control and imitation, is very important, not only intention of movement, but how we are able to imagine our movement and how we are able to imagine how to restore control of the movement. And the meaning of the action is so important when we focus on different training where intention, how we imagine the motor control, and the meaning of the movement that we are doing is a key point to transfer all the information that we need from outside the body to inside the body through technologies. Some example about how it's possible to do this. Why we need intention, engagement, embodiment? Because we would like to increase the ability to have something that the patient will be able to analyze after the exercise time spent during rehabilitation. Means that we need to stress memory of our activity to be able to restore the control of our activity. Then again, dynamic interaction, experience non-linear interaction. And when we are doing something able to change the experience of the patient, it's very important to be able to stress and to start to look how it's possible to decide which kind of action we are able to perform, depending on a number of possibilities that we have. Means that we are moving from motor control, single motor control, goal and task related, to a behavior of the patient able to control the body to restore function in terms of interaction more than action. And when we look the problem from the point of view of behavior of the motor control, it's very important to stress the concept of perception of the movement. That means that it's possible to use technologies to stress the problem from the point of view of the perception of the movement, to integrate perception and premotor area activities to improve motor control in terms of selection of the movement that we would like to perform, in terms of behavior related to the movement that we are doing. Then it's very important to look plasticity as a perceptual motor skill able to reshape learning process, to maintain the activities that we are able to perform during training session after the training session. And to try to do this means that during the activity related to exercise, therapeutic exercise, and after training, we have to look the brain that is the key factor to maintain all the situation under control as an inference enzyme. What means? Means that when we are doing something using a technology to restore a movement, we are in a situation where we don't like to simulate a movement, but to emulate a movement. What means simulate or emulate a movement? When we are able to have an internal software inside the brain related to the movement that we would like to perform, when we have a stroke or traumatic brain injury or any other lesion of the central nervous system, we maintain our idea of the movement that we would like to perform. We are not able to do this. Then, when using a technology, we will perform an action. We will perform an action depending on the internal model that we have of the movement. And when we have a very close interaction between the internal model that we have inside the brain and the movement that we are able to produce, and we have a shift between what we would like to perform to what we are able to perform, then we have an inference of the activity that we are able to perform. Means that through to this, we have a plastic generation of connection able to reshape the motor control. This is a model related to Freestone Group in UK, where we stress the fact that the sensory input and the predicted action and the pre-motor control is very important to define then the precision of the movement that we are able to perform. Means that interaction and prediction of the action is very important to perform an action. Is that exactly what happened during any technological treatment that we are performing? Then, more important, intentional and perception of the movement than the number of repetitions. And prefrontal cortex is a very important place where we work during this kind of exercise. Then prefrontal cortex able to interact with motor cortex and sensory cortices and the autonomic system too. Then when we look plasticity and neuroplasticity in terms of motor control means flexibility of the behavior that we are able to restore, and flexibility means the ability to change or to adapt our motor control to the context where we are doing something, using high-level controller and low-level controller, and I would like to stress again, related to internal model that we have. Means that we have to be able to understand where we are in terms of space, when we perform something in terms of time and timing, then intention in the space with specific timing to spend time to perform activities to restore function. Space around us, and a space of our body too. Very important using technologies that we restore a connection between part of the body that due to brain lesion or spinal cord lesion lost the connection with the body in terms of function, even if anatomically they maintain relationship. Then action experience, egocentric action experience using a technology means try to restore a connection between your brain and the part of the body where you don't have the control. And timing is very important. Timing of the muscular pattern that we are able to produce using any technological support, smoothness of the movement, and efficiency of the movement that we are able to perform, related to our intention, to our ability to maintain strict relationship between internal model that we have inside the brain and the action that we are able to produce. Using this affordance, like the ability to think that our body is again able to perform action as we like. Through technologies, it's possible to restore body ownership in terms of the feeling to maintain under control our body. Because one of the key points of the patient that we have to treat to restore motor control is that They don't have under control the body, and they have a disembodiment of a part of the body without any motor control related to this. Then body ownership and sense of agency is very, very important, strictly related to the meaning of the body, meaning of the movement, consciousness, and embodiment of the part of our body that we maintain under control during exercise through technologies. Then the human movement is related to internal model related to genetic and epigenetic factors. Then it's possible to look plasticity as an epigenetic situation. Epigenetic situation that we are able to stress through technologies. Then epigenetic is a crucial part of plasticity. And we are able to see all the remodulation of the motor control as an epigenetic system able to change connection at brain level and in spinal cord, but at level of the muscle, tendon, and bone too. Then means that if in the first part of my presentation, we stress the fact that interaction between patient and technologies is a way to reshape motor control in terms of brain activity. In the same time, it's very important to think interaction between body and technologies in terms of mechanobiology. Mechanobiology means that during exercise, we perform physical interaction able to change structural activities inside the muscle, the tendon, and the bone, and we are able to reshape peripheral part of our body like we are able to reshape our brain. Means that it's possible to reshape the muscle, not only the brain, using exercise able to stress the system in the right way with the intensity and with continuous treatment that we are able to perform using technologies. Means that when we are performing an exercise, we are performing something able to reshape the motor control, the sensory motor control, but in the same time, we are able to stress the muscle and to change the quality of the muscle from a metabolic point of view and from a rheological structure point of view. This is a typical situation that we have under control inside the muscle due to stretching related to movement. We change stiffness, and we change stiffness, and in the same time, we change the activities, for example, of the intrafusal muscle fibers that change completely sensory information related to mechanical stress of the muscle during exercise. Then rheological properties of the muscle and plasticity of the muscle change the control of the muscle too. This is a slide where we try to stress that we are able to look plasticity as a bottom-up process through all the activities related to intention, embodiment, engagement, and learning process at brain level. And in the same time, we have a top-down activities and plasticity related to muscle, tendon, spinal cord, to maintain working memory, to maintain ability to predict the results of our activity, to predict the error, and to maintain under control the outcome. And the technologies that we are using are exactly the interface between this bottom-up and top-down process. Then technologies are something that support our work to restart, to think how we are able to control our movement. Means that we learn something using this physical human-robot interaction to be able to emulate and to reproduce the mechanism that we are able to use typically to maintain under control the situation. And this is a typical representation of all the area of the brain that you are able to stimulate during exercise in terms of premotor, sensory motor control, and coordination to reach the possibility to activate the motor cortex in the right way, with the right timing, with the right intensity, to maintain under control flexibility of the action and the timing and smoothness of the movement too. If this kind of slide is related to upper limb, is exactly the same if you look the lower limb, where on each step we have a lot of information, sensory information that move to the premotor area, and then we move to motor cortex, and then we have the outflow. Then by this way it's possible to understand how we are able to push plasticity and to modulate different situations. Again, when we are looking some specific part of the brain where we have plasticity or where we have a modulation of plasticity, insula is a very important part of our brain, particularly on the right part of the brain, because in this area we have a lot of processing related to body ownership, sense of agency, and body image. We are looking more or less the end of my presentation. Then we have to think plasticity as a remodulation of motor and sensor condition that we stress during exercise through technologies able to interact with the patient to maintain the ability of the patient to perform something that the patient would like to do. Then intention of the patient is the key motor of this kind of exercise. Intention, interaction, more than number of actions that we are doing. Because the model is a model of connectomics, where we need to have a lot of interaction between different parts of our brain to perform any activity that we would like to perform, moving from the concept of movement to goal, task, and behavior. And genetic factor will be very important, because depending on genetic factor of the patient and epigenetic related to genetic condition of the patient, we will be able to modulate our motor control after any brain injury or any spinal cord injury in a different way, depending on the technologies that you are using, the right technologies in the right moment, but in the same time, the right patient with the right technologies. This is very important to be able to know that patient first, genetic condition of the patient, epigenetic condition that we are able to change and to push, and technologies able to introduce in the system a new way to reshape, starting from genetic and epigenetic concept, the ability of the patient to maintain under control our body and the interaction of the body with the real world. Thank you very much for your attention.
Thank you very much, Dr. Molteni. Thank you. Now is the moment for Alejandro to talk about his experience in Neuroplasticity. Thank you.
Hello. Okay, I think I can talk. Okay, perfect. I will try to. Hello, everyone. I will try to share my screen. Okay. Here we go. I think we are now. Okay, well, first of all, thank you so much for the invitation of being here. I want to thank the Gloreha team and also my colleagues from the IRF La Salle and Robotic that made, with all the support, this possible. And well, the purpose of being here is about to share my experience as a physiotherapist specialized on this type of technologies, and also share some research, some studies that I found interesting to share. First of all, I would want to start with a reflection, with a thought that when we are going to do a neurorehabilitation of a patient, we have to take care about three, there are more, but three main ingredients or principles during the rehabilitation. One of them is the repetition. We know that if we repeat some task, I'm talking about, for example, gait, I'm talking about grasp or pinch. If we repeat that movement along the time, we are able to increase that motor learning. And here comes the new technology for rehabilitation, because if we take, for example, an exoskeleton or a FES, a functional electrical stimulation, we will be able to perform such repetitions in a short term. So it's a really, really important thing to think about. Also, the intensity. I found out that intensity, it's sometimes like an open concept, but one thing is clear is that we need to measure the patient, and in that field, the technology help us to measure that. I will bring an example again for with an exoskeleton, for example, the Exobionics, what we use here in IRF. We can set the assistance of the swing phase of the gait of the patient into, for example, 65% of the capacity of the exo. And we can realize that the patient are able to do that step. And then we can decrease that assistance for example, 55%, and then we realize that the patient can afford that movement. So at that point, we know where is the maximum of the patient, we know where is the roof of that patient, and we know where we need to push. And if we are doing an intensive therapy, if we are asking the patient at that point, we need to know that value, and we need to know how much are we asking the patient. Functionality is another ingredient really, really important that actually most of the new devices think about it and work with it, because we know that when we set an environment and a specific task related with the function, we can bring more neuroplastic change, comparing doing a simple movement related with, for example, gait or grasp, but without doing that functional task. I found mandatory to talk a little bit about neuroplastic adaptations, and these are like some items related with also neuroplastic adaptations. We know that experience is really important. We can think about gait with compensations, or a patient who can't walk, but we are trying to teach him to walk. And the exoskeleton, again, in this case, can help us to reduce that compensation and to give the patient that information we want him to do when we remove the exoskeleton and ask them again to walk. So if we give the experience to the patient, we can go into that neuroplastic adaptations. I talked earlier about intensity and competition, or let's say also motivation is something that is also really, really important. I will bring again an example when we finish a day of therapy with a patient with the exoskeleton. We tell the patient how much steps have they done. And that's a really good feedback for the patient, because he really understands what has he done. He will want to increase that number the next day, and it means that the patient will be compromised with the therapy, will be into his own therapy, and the motivation will increase, and it will help us to reach the goals we have with this patient. Obviously, we have to clarify that not everything is repetition, not everything is do more steps. As we see here, we have some other things we have to take account, not only repetition, but it obviously is one thing really, really important. I'm setting the example of the exoskeleton, but we can talk about functional electric stimulation, or we can talk about other type of device. Is the same. Also, we found out that these new technologies make the patient happier, because it's funny to do rehabilitation with video games or with exoskeletons. You find more entertainment comparing a conventional therapy. Also, time is really, really important. If we do the same repetition or more repetition in a wider window of time, we are going to get more results. Well, summarizing all, this is like all the main concepts we take care during our rehabilitation with our patients in here in the IRF La Salle. And I think it could be interesting to talk specifically about some devices we used to use, and we will show you some videos, also clinical videos, to see how does it works. Well, I will start showing the Gloreha Sinfonía. You may know that we have here in the occupational, I don't know if you can see, in the occupational therapy room. And well, probably you may know for what is Gloreha Sinfonía. Is a globe and exoskeleton from the hand that help us to do passive and active assistive, also active mobilization with feedback. And we can do it global or selective movements. It works with two strong principles. One of them is the functionality, is the ingredient we say at the beginning of my speech, is that we have the hand free to do functional tasks. And well, the other principle we have to take care is the combination of other therapies that we know that already work in this type of patient. I'm talking about motor imagery, I'm talking about action observation. We have the chance to set the Gloreha to put the video just before we are doing the exercise. So we can do an exercise of action observation, and then we do the exercise. And during the exercise, we have a lot of feedback. We can have feedback from sensory outcomes from the globe. We also have a visual feedback, because the patient is looking his own hand, and also is looking the screen that give us the representation of the hand. And well, we know that all of this promotes plasticity and motor learning, because we are giving so much feedback by different sides to our patient. I won't go into deep from some studies because we don't have enough time, but I found really interesting to share this study that found out results really interesting about the passive robot assisted training, and it shows up that may achieve some cortical neuroplasticity, and well, I invite you to read it, because it's really, really interesting. We are not only looking for neuroplasticity, because we have another goals also. And well, this type of technology show us, as long as we are doing exercise, that we will have other benefits. I'm talking about decrease, decrease of spasticity, increase of manual dexterity, range of motion, strength, and all these outcomes are because, in fact, we are doing exercise. We are helping the patient with the exoskeleton in this case, but we are doing exercise. As physical therapists, we know that one of our best tools is the therapeutic exercise. So we have a long support of evidence that show us these benefits. And well, at this point, I would want to share a clinical video of one of my patients. We are working with Gloreha. Is a patient that has a spinal cord injury. I will meet because he's in Spanish. I will talk better. Okay. And well, as you will see, I'm asking now the patient to do pinch. As you will see, we have a lot of activity of compensation with the extension of the wrist, and not such movement with the thumb. I will show you. Okay, now I'm resisting this compensation, and I'm asking again to do the same movement and see what happened. This is at the beginning of the first season, and then we are going to into functional activities. This is a sequence of different pins. This could be like a passive exercise, but it's not at all passive, because we reduce the range of motion we want to do the Gloreha, and we ask the patient that with this range of motion, he has to finish that movement. Also in the extension, you will see that the patient have to extend before the Gloreha extends the square. Okay, this would be another example that I'm not using the hand as a conventional way, but this is bilateral therapy. In this case, I have the sensory glove in my hand, and I'm trying to do with my patient some strength exercise. In this case, I bend my fingers, and it will be a mirror on his left hand, and the device will help also to bend the fingers. In that point, I ask the patient to keep this finger flexion, and I will open my hand in order to search like an eccentric exercise and increase that grip strength. Okay, as you see, now I ask them to grab, and I will release. I will extend my fingers, and he needs to hold on. Okay. There we have these results intra-season of this patient. As you see, we have so much movement on these two fingers, and also we gain a lot of the extension of the fingers. Okay. Well, you have seen this bilateral therapy, but I have to say that conventional way to use is that, for example, in a stroke patient, we set the sensory hand on his healthy hand and the passive hand on this hemiparatic hand, and then we can do dynamic mirror therapy. I bring here a study that I found out interesting to share how could be a program of therapy with this device. In the case, the patient we have seen now in the video, he comes here like 2 days a week only for do Gloreha, and then he have obviously other robotic therapies and other conventional therapies with us. And well, I will continue with another device that we have here that we use daily. This is Unova, is a dynamic posturograph. you may know that dynamic posturograph is a system that consists on measure the displacement of the pressure sensor in the platform and give us information really interesting about the balance of the patient and some systems that are enveloped on the balance. There are two main big groups of posturographs, the static posturographs and the dynamic posturograph. The main difference between one and the other is that dynamic posturograph, the platform move and can do accelerations and perturbations. So is a really good device to put more effort on that vestibular system. One big difference between UNOVA and another posturograph is that, as we see, we have a robotic chair that it works like a posturograph, but in a sitting position, and with it we can work the stability of the trunk and the stability on the wheelchair. As you may think, the UNOVA is a tool for treatment, is also a tool for evaluation. We have the advantage of the new technologies that show us evidence that we give a report of all exercise we have done. Here in this slide, we can see 3 different exercises. I think you can see the mouse of the computer. In this case, it will be an static exercise. A is open and A is closed, and we have the reference between the normality, and we know in this case that with this patient, for example, we have been too far from the normality, and maybe we can extract some conclusions about it. The main point of it is that we know what is the weaker point of the patient with this, and we know where we have to work and where we have to push. And also the device will suggest us how do we work with that patient and how we be needed the difficulty to set in this type of exercise. Following with other devices, I will talk a little bit of the EXO from EXO we know that the EXO help us on the rehabilitation of the gait, and we know that there are good results in stroke and spinal cord injuries patients in functional outcomes. But I wrote here this study that I found really interesting and related with neuroplasticity that show us the changes of EMG and well, with this type of studies, we can say that we are pushing the patients into changes, and we are going into neuroplasticity. In fact, this is one study from Dr. Franco Molteni. Well, the EXO is not only for stroke patients and spinal cord injury patients. We have to think that is a tool for train walk and for reeducate that walk. And well, in Spain, for example, we are using a lot in EM patient and also in cerebral palsy patient. And well, we have just to take care about the contraindications we have and use it as a tool for rehabilitation. One of the last devices I will show you is the FES, the functional electric stimulation. I bring here 2 videos comparing the gait of a patient without the device. In this video, you can't see the device. The device is behind the trouser of the right foot of the patient. And well, let's see the gait of this patient, the stroke patient. As you see, we have that common foot drop issue in that type of patients. Okay, and here we have the device activated. Is clear. We can see such difference between the other video. We can talk about gait symmetry. We can talk about we are doing more steps in that window of time, and we can talk that we are not fixing the ankle in this case. We are not fixing any joints. We give the patient the challenge to activate by itself the muscle, and also we are doing the feedback. We are giving feedback of which muscles we want to activate with the FES. So as you can see, all these devices can match perfectly about the ingredients or the principles we were talking about the first minute of my presentation. We are gaining functionality because we are gaining more gait symmetry and more steps. We also are doing more steps, so we are gaining repetition, and we are not fixing the ankle. We let it free, and we give the opportunity to work during the gait. So we are also working with a parameter of intensity. Finally, I would want to share a different device. We have more, but for time, I won't show more. This is VibraMove, is a unique device that uses a unique principle that is called FPS, functional proprioceptive stimulation, that with a vibration on the muscle, stimulate the muscle spindle and give information, fake information, let's say, about a movement, about amplitude of movement and a velocity of movement. So this is a challenge to work proprioception, to start training the movement, and a really good device for matching with other new technology device like exoskeleton or FES, and of course to match with conventional therapy. And well, I think from my side, I said very all. I want to make one last reflection, one last thought about is that the technologies won't replace the physical therapies or the occupational therapies. They are just a tool that we use, and of course is a tool that is here for help us. And well, we already know because of our clinical evidence, and also we are researching, and we know that the path we have to take is the path with this type of technologies. So from my side, this is all. Thank you so much for your attention, and I will try to answer any question.
Thank you, Alejandro. Thank you, Dr. Molteni. Very, very interesting presentation from you two. Really, really, I enjoyed both of them. And I think now that is time to some questions, because I saw that in the Q&A section, there are a few questions to talk about. So I will just read them and post to you just to give some explanation to our attendants. So the first question comes from Mrs. Eva Barich. What are your experience with children with cerebral palsy? So I think that maybe Dr. Molteni can reply to this question.
We have some experience in CP patient too, and it's possible to use robotic system in a right way. It depends on the morphological condition that we have to face, the dimension of the hand or the dimension of the whole body, but it's possible to use it, and the young patient enjoy a lot to use technologies during any rehabilitation treatment. I don't know if Alejandro have any experience about this. We have some experience, excellent experience too.
Yes, we do. We do have here a pediatric section also, And we have also, if you want, we can share some evidence. There are research about the use of the EXO with cerebral palsy. Also, we remove for the management of spasticity. And also, we have a pediatric FES that we use with this type of patients.
Thank you. So the next question comes from Mrs. Antea Krusek. I don't know if I pronounce it right. She asks if are there and how big are limitations in restoring functions in case of spinal lesion? So this is, I think it's a question for Dr. Molteni also.
Obviously, if you have a complete spinal cord lesion, it's very difficult to think that you are able to, even if you have plasticity, that you are able to restore function. But in the same time, the new technologies that we are able to use in spinal cord injury patients and the fact that we have a lot of incomplete spinal cord injury patients at cervical level or dorsal level, we realize that intensity and tension and change of the muscle related to exercise are able to push plasticity at spinal cord level. There are some basic science data related to ability of the movement to restore activities inside the spinal cord, changing the ability to have a plastic change of motor control and sensory motor control too.
Thank you, Dr. Molteni. The next question comes from Mrs. Elena. I think that maybe this is a more question for Alejandro. Do you have any TDCS experience paired with Gloreha? She asks.
It's a great question. I thought about it, but I don't have experience matching Gloreha with TDCS. I think it could be really, really interesting research about that.
The question is a very important question about neuromodulation during robotic exercise. The key point, and in this moment, no one is able to have an answer, if it's better to perform neuromodulation before the treatment or during the treatment, or sometimes immediately after the treatment. Because neuromodulation means a lot of different things, means to prepare the brain activity to exercise, or to increase brain activity during exercise, or to increase the ability to have a memory of exercise after training using TDCS. And TDCS, transcranial direct current stimulation, is completely different from transcranial magnetic stimulation, completely different situation.
Thank you. So the next question, I think that already Alejandro and Dr. Molteni answered, because Mrs. Manova is asking, when presenting cases, just to specify if it's a spinal cord injury or stroke. So in each case, you specify which one is the type of case. So I think that we can just skip to the next question. The next question is very interesting. Mrs. Crumbold is asking, do you use virtual reality in your rehabilitation? This is a very interesting one. I think you both can reply.
I'm not an expert of virtual reality. I have colleagues that they already use. We have here a system with glasses, but I don't know if Dr. Molteni has more experience. I think yes.
Virtual reality is another way to change the experience of the patient during treatment. Obviously, we have to use virtual reality. We use virtual reality too. Be careful about the position of the patient during virtual reality experience. Stay in sitting position, because in standing position maybe that you have some problem because the patient move inside the virtual reality and collapse. This is a key point. Another key point is if you have a seizure. patient with seizure, we have to be careful to use virtual reality. But virtual reality is an excellent way to change the experience of the patient during movement control and to increase engagement and to increase embodiment too.
Very interesting. The next question comes from Mr. Mercante, Andrea Mercante. He's asking, what about botulinum toxin? Is it better to inoculate before, during, or after robotic treatment? I think this is a question for you both.
Well,
or Molteni first, so how do you prefer?
I can talk. I don't mind. We try to use exoskeleton after and before, and I can say it's one better than the other. But we found better results doing it just before. I mean, just after the botulinum toxin.
I agree that exercise is a neuromodulator system. And as I try to explain the effect of exercise on the rheological properties of the muscle, may be very important if you have spasticity to try to treat the patient using technologies. Then if you have a spasticity that block the activity of the robotic system that you are using, please inject the muscle, reduce spasticity, and then perform more and more exercise using the robotic system.
It's important that most of the devices have a formal contraindication when we have 3 plus or 4 of Ashworth modified scale. So in this case, we need to reduce that spasticity because we can't work with that type of device.
The next question is also very interesting. It comes from Mr. PM. He is asking, is there a significant difference in time to restore motor ability between using robotic devices that can perform very complex movement, for example, finger, hand, arm coordination, and devices that perform simpler movements, for example, pinching? I think this is a question right for also Dr. Molteni.
It depends on the ability of the patient, but in the same time, maybe that you have different steps of complexity of exercise, depending on when you are doing something, what is the goal, and the motor control of the patient that you are able to check before the treatment. Obviously, it's very important to perform some simple movement, but it's so important to have complex movement to introduce the meaning of the movement, the goal and task, and not just the motor control.
Thank you. We have 3 more questions, and the next question is for Alejandro. Good evening there from Lee. My question to Mr. Alejandro is, I just want to know if the robotic technology will be able to bring our transference to clients, as most of the clients are not having such equipment at home. So I think that he wants to understand a little bit what happens in having technology at home, or how we transfer this technology at home. I think that the question is this.
Most of the device we have talked about are device which they propose is rehabilitation on clinic. But for example, with the FES, the orthosis of the last video we have shown is a device that a lot of patients have in their home. Instead of an orthosis that fixes the ankle or a foot up or something like that, they want to bet with new technologies. If the question goes around the exoskeletons or robotics, I know companies are working about it. There are some exoskeletons on the market designed for mobilization at home, but at the moment, I think, and maybe Dr. Molteni can help me, but I think that there are not too much research about that new exoskeletons for use at home.
I totally agree, Alejandro. In this moment, we have a lot of robotic device to treat the patient inside the hospital, but very few device to treat the patient outside the hospital. Maybe that the next generation of robotic system may be more simple in a different condition of the patient, will be able to support the patient at home. And then is a very important explanation about how to perform a continuum of care using technologies. But in this moment, we need more different robotic device to treat a patient at home.
Very interesting. I think that the next question is for Dr. Molteni. Haris Manova is asking, what is the learning curve change during usage of robotic therapy when compared to normal therapy curve?
Nice question. Generally speaking, maybe that using a robotic treatment, you are performing exercise in a different way. Then it's very difficult to compare conventional treatment versus robotic treatment. If you would like to compare just gait training, for example, conventional gait training versus robotic, generally you anticipate the learning curve of the patient using robotic system. In any case, it depends on the condition of the patient, motor ability, and cognitive condition of the patient too. It's very important to mix all these different situations to define exactly the learning curve.
Thank you. The next question is for Alejandro. It comes from Roberto. He asks, have you used technology and aquatic therapy into ERF pool?
In ERF we have a pool, but no, we don't have yet technology that we can get into water. Is also a contraindication for most of our devices, but it would be nice to develop some devices to mix that aquatic therapy and also robotic therapy. It's interesting, yes.
We have two last questions. So one is for Dr. Molteni, one for Alejandro. I will ask to Dr. Molteni, what is the carryover in hemiplegia for hand function and how much intensity and frequency of robotic therapy is needed? Mrs. Arcana Ranade asks us.
The carryover effect is a very important problem that we have to face. And in this moment, no one is able to define exactly the number of sessions that you need to have a carryover effect. Why? Because first of all, until now, we look the problem in terms of localization of the lesion, but to try to have any idea about carryover effect, we have to increase and to improve our ability to define the lesion in terms of connectivity. Maybe that we have to know what means interhemispheric disconnection and carryover effect, first of all. And second one, in terms of carryover effect, is depend on the plasticity of the system too, that depends on a lot of different biological conditions, because different patient means different ability to have plasticity due to genetic and epigenetic factors. Then, in this moment, no one is able to answer. For the future, we have to define connectivity of the patient and biological biomarker able to predict the ability to restore using a plastic change connectivity.
Very interesting. So we have a last question from an occupational therapy. Her name is Ilaria. He asks to, I think, Alejandro, can I use this glove in the preparatory phase to accustom the patient to a specific type of sensation or motor grip in view of an activity such as fishing, for example?
You can't move. I don't know if I understand well the question, but you can't move the device from from the place where it is. So if you want to work with a functional way, you may use items like bottles or glasses of water or well, we can do exercise with a lot of things. I didn't try with fishing stick, but you have to think that the device only help us in the flex extension of the fingers. We also have, I will show you because I have here, and I think it's more constructive to show it. We also have this support brace, okay, that you can set the level of strength you want to degravitate the patient, and then you can work with the patient in a sitting position. Maybe if you have a tall table, you can work also in a standing position, and you may try to find a way to do more and different functional tasks. The imagination is the limit in this case, but I didn't try with such activity as fishing.
Waduda, I would like to stress the last example of Alejandro, to stress that the position of the shoulder from a neurophysiological point of view is very important, because depending on the position of the shoulder, change the threshold of the activity of the motor cortex able to control the hand. Then different shoulder position means different possibility to control the hand in terms of cortical motor control. It's very important, this example, very important.
Yes, yes, very, very important. So I think that we have a last question that came here, and it's very interesting, and I think that is for you, Dr. Molteni. Always, Mr. Menova asks, can therapeutic robots do functional and complex assessment in future?
This is a very long discussion if we have to use a robotic device to perform functional evaluation. May be possible to use it, obviously strictly related to clinical evaluation. For example, maybe an excellent way to analyze the ability to have an acute change of the EMG pattern depending on the motor control that we are able to support using a robotic device. This is a way now to check if you have plasticity of the system immediately. This means ability to check short-term plasticity after minutes of treatment, completely different from a biological point of view to the medium and long-term plasticity. But using this device, it's possible to check if you have short-term plasticity.
Very, very interesting. So I think we are over with the questions, and I will very thank you, Dr. Molteni and Alejandro, to exchanging your experiences and talking from the two places so far from the other, because Dr. Molteni is in Italy and Alejandro is in Spain, so we are exchanging point of view and experiences also from different countries. Also, our participants come from a lot of different countries, so thank you very much again to everybody. And I just want to remind you that at the end of this webinar, you're going to see a pop-up that comes out from the screen asking if you like the experience or not. And we are collecting some suggestions and ideas for the next webinars we have. So just please fill in if you want the quick questionnaire. And I think that we are done for today. Thank you very much again to everybody. And at the end, you are going to see also on the screen webinar cycles we are organizing. So if you want to participate, just please stay tuned. And for any further question, you can contact us. So have a nice evening to everybody, and thank you again for the participation. Have a nice evening. Bye, Dr. Moteni. Bye, Alejandro.